Dr. Matsumura, thank you so much for joining me today. Let's talk a little bit about your journey into sleep. You've been called the sleep goddess. So tell me about that. How did you come up with that name and how did you get interested in sleep and menopause?
Yeah, so I am an internal medicine by training, first and foremost, and I practice primary care and hospital medicine for the first 13 years out of practice. And I kept on hitting a wall, if you will, when I was working with my patients and their chronic medical conditions. And I realized when I started asking one question, which is, how many hours of sleep do you think you're getting? I had gone to some sort of CME and I thought, "Oh, that's a different way of asking than just saying, 'Are you getting sleep?'" Right? So I asked, "How many hours of sleep are you getting?" And I was blown away by the fact that most people said, "Oh, I don't get any sleep at all," or, "I don't know, I think I get about 5 hours every night." It was just common. And it was not only common, but it was almost as though people were just resolute to it. So that's how I started thinking there's something more to this. And I'm also being asked to prescribe sleep aids all of the time. Fast forward to I am in an ACLS class and a pulmonary critical care and sleep doc says, you should go into sleep medicine. I applied for a fellowship in sleep medicine and I ended up leaving my career as an internist after 14 years. I went and did a fellowship in sleep medicine. And then I started working in a multi-specialty private practice, and I was inundated with women who were coming to see me in consultation who were having a lot of trouble sleeping. And I realized that there was this hormone connection. And so then I started to focus on women and sleep. And then I thought to myself, everyone should sleep like a goddess. So then that's how it all came. That's how it unfolded. And I developed my brand, Sleep Goddess MD, and I wove into my method developing your chronotype, which is an archetype, which are famous female mythology heroines.
I love it. And sleep is something that everybody has to do. It affects every person. And so that's why I think it's such a fascinating field as well, because all of our patients have to sleep, yet most clinicians, whether you're a physician or nurse practitioner or another type of clinician, hardly get any training, maybe 1 or 2 hours of sleep education.
Uh-huh.
Yet it's such a foundational aspect of health. So today we're going to talk a little bit more about menopause and sleep.
Yeah.
And we were just chatting before, there's a huge boom of interest now in menopause. I think a lot of doctors, our peers, are going through that stage of life now where a lot of us are going through perimenopause and menopause. So there's a personal interest as well. So let's talk a little bit about the changes that we see in sleep during menopause, and then we can get into some strategies for people.
Yeah, definitely. Yeah, you're right. I think we hit a tipping point. There are enough female physicians who are going through menopause that realize there's got to be more than this. And you mentioned something really important, which is the fact that we get little to no training around sleep medicine in our training. And that's true for menopause and women's health as well, right? So that's why there's this moment, but I think the moment is here to stay. We need more data. And some of the things that happen with women and their sleep when they're starting to hit that perimenopausal state and then go into menopause is the fact that with the reduction of estrogen, then you have a lot of middle of the night awakenings. And that is really because estrogen plays a role in calibrating your temperature, right? And we all know that when we go to sleep, we have this slight reduction in temperature, and that helps us stay asleep. And so then you have this inability to regulate your temperature that is in the hypothalamus where this happens with this reduction in estrogen. That's just one component. Then there is data out there that shows that estrogen reduces the deep sleep and also can, with the reduction in estrogen, you have a reduction in deep sleep or slow wave sleep. And then you may also have some reduction in your REM sleep as well. Then the other component is progesterone. So progesterone typically is this GABA promoting hormone that really allows us to relax and get to sleep. And when we have this reduction in progesterone, then we don't have as much ability for some of us to actually get to sleep. And then we have this sleep onset insomnia in addition to the middle of the night awakening. So it wreaks havoc on women's sleep. And that may be the first symptom in the perimenopausal state.
I asked in a Facebook group once, it was predominantly women in that group, what's your biggest problem with sleep? And this is exactly what they said, was waking up in the middle of the night. What are some of the other changes that we might see with regard to melatonin and sleep? And is melatonin something that women should be taking exogenously? Or what are your thoughts on that?
So I have been doing a deep dive on melatonin because I started to think about the longevity space and realizing I'm not really interested in living longer, but I am interested in maintaining my quality. So I think that's what I tell my patients. My job is to maintain the highest quality for you for as long as we can. And when we don't treat medical conditions with the knowledge that we have currently, your quality may suffer. And nobody wants that. So when I think about melatonin, I was surprised to see in the literature that the pineal gland is the first gland to calcify in our body. And we have this reduction of pineal sites. And that's the normal, quote, aging process. However, I think that for women, we get this double hit because with this reduction in estrogen modulates serotonin as a precursor to melatonin. And so I think that we not only have the natural aging process of a reduction of melatonin production endogenously in the general population, we also have this reduction because estrogen also plays a role in modulating the production of melatonin. Now, the data is really split in the premenopausal state. I don't think there have been many studies. Actually, I can't find any studies in the postmenopausal state and how estrogen or the lack thereof may play a role in melatonin production. But the data for the premenopausal state, it's really split that it does impact melatonin production and it does not impact melatonin production. So I think we need more data, we need more research, but I am convinced that there is some connection between estrogen, melatonin, aging, and dementia.
What are your thoughts on taking melatonin? Should women be taking it? And yeah, what do you think?
Okay, again, that's also quite controversial, but I myself have started taking 3 milligrams of sustained release melatonin. So then I started taking a look at the data to see, should I be taking 0.3? Should I be taking 1 milligram? What am I taking it for? How should I take it? So I take 3 milligrams of sustained release because that mimics our physiology the best. And I take it 2 hours before I want to go to sleep. So I generally fall asleep around 10. I get into my bed at 10. I fall asleep pretty quickly, but I take it a couple of hours before I am going to get into my bed. So I take it around 8 p.m. for myself. And I feel like it really helps me stay asleep. So as a sleep doc, when I hit perimenopause, I just didn't know what to do with myself because for the first time in my life, I had insomnia and it was debilitating. And I started on hormone therapy, which was life-saving for me, estrogen and progesterone. But I still had these middle of the night awakenings, not every night, but maybe 3 or 4 times a month. And then when I started diving deep into the literature around melatonin, I thought, is melatonin the next vitamin D? Do we just not know enough about it? Because it not only helps with sleep, but it's got immune protection. It helps with potentially with our cardiovascular system. It's doing a lot of things that really haven't been thoroughly in the literature yet.
Yeah, it's such a fascinating hormone. Now, I want to go into some of the sleep disorders that we see during menopause, but we'll come back to that because I wanted to clarify the dosing as well, because that's a question I get a lot from people. What's the right dose of melatonin to take? And there's 0.3 milligrams. Like you said, there's like doses that come in 10 milligrams. How do you navigate that?
So, the first and foremost, you want to take a supplement that is third-party tested, right? So there's a lot of brands out there that I likely would not recommend, but I don't really have one particular brand that I would recommend. What I typically tell my patients is find something that has that NSF label on it. That's the third-party testing. And then the second piece is when I started really diving deep again in the literature, I am not trying to realign a circadian rhythm. I'm trying to get to sleep and stay asleep. Those are two different things, right? And so then when I was reading through the literature, 3 milligrams sustained release seemed to mimic physiology and how we use melatonin the most.
Before we jump in, I'd like to invite you to get my free melatonin brand guide. When it comes to melatonin supplements, quality matters. So if you ever recommend melatonin supplements to your patients, you need to get this guide to third-party tested good quality supplements. You can get it at intrabalance.com/melatonin.
And then with how it gets metabolized in the body, how much active ingredient you're actually getting. As long as you're giving yourself 7 to 9 hours of sleep, I do think that the 3 milligrams sustained release is going to be your best bet. Some people may not need that dose. Some people might do just fine with 1 milligram sustained release. But I did find in the literature and even anecdotally with my patients, if it's not sustained release, people say, it helps me get to sleep, but it's not helping me stay asleep.
That's an important distinction. And as you mentioned, there's a different dosing and timing strategy for circadian disorders. So I have a video on that. So if anyone wants to take a dive into that, I'll post that link. Okay, so when we're talking about sleep issues in perimenopause and menopause, one of the most common issues is difficulty staying asleep or having nighttime awakenings. And there could be lots of different reasons for that. Hot flashes or vasomotor symptoms is one. You mentioned insomnia. Could you share a bit more about some of the common sleep issues and sleep disorders that we see in perimenopause and menopause? As you can see, there's a lot to learn when it comes to clinical sleep medicine, and we're just scratching the surface in today's interview. If you are a physician or a health practitioner who wants to learn more about clinical sleep medicine in a practical way that you can use in your everyday clinical work, then get my free sleep mini course. I'll put the link to that in the video description below. You can also get it at intrabalance.com/doctors.
Absolutely. So that's really why I developed a more holistic, integrated, comprehensive approach when I am evaluating somebody's sleep, because obstructive sleep apnea is a biggie. So in the postmenopausal state, you might be waking up in the middle of the night, not only because you had vasomotor instability, but also because you might have trouble breathing in the middle of the night, right when you're in REM sleep. As we both know, women tend to have REM-related sleep apnea. It's not hard and fast, but generally speaking, I do see that pattern more often in women. And especially in the postmenopausal state, women have just as much risk for sleep apnea as men do for a variety of reasons. So estrogen and progesterone did have some protective ability with keeping the tissues that support the airway open. And so with that reduction in estrogen and progesterone, even if you're on replacement therapy, there's still a change physiologically in the back of the throat. And then we tend to gain a little bit more weight in the middle area, which can contribute to sleep apnea. So that's a biggie for me. The data out there, the literature will have a range, but the high end of that range is up to 67% of women in the postmenopausal state will have sleep apnea. My concern is that home sleep apnea testing, which is what most insurances cover, don't capture that. So we are not capturing the diagnosis of sleep apnea in women like we should be. And a lot of people will just stop at a home sleep apnea test and they'll say, it's negative. Sorry, you're just having trouble sleeping. The other thing is the development of chronic insomnia itself. So I always tell folks, hormones play a role, but there's a lot of other things that can be causing your problems in the middle of the night. And the other thing is restless leg syndrome. We know that estrogen plays a role in iron store, and ferritin levels may be more important in the postmenopausal state. And you and I both know that and having been a primary care physician for years, the range of ferritin is wide for normal. And now I am a firm believer, if somebody is having trouble sleeping, I just say, let's push that ferritin up to over 100 just to be on the safe side, even if it's not specifically restless leg syndrome or periodic limb movement.
Absolutely. That's my approach as well, is let's get that ferritin level up, because you may not just see restless leg, you can see restless sleep or just poor quality sleep in general, and then fatigue and cognitive brain fog and all of the other things that come along with that.
Right.
Yeah, and I think it's really important that you mentioned that home sleep tests may be insufficient in women, because sleep apnea can show up quite differently in women than it can in men. And women don't often have the classic symptoms of the loud snoring, the gasping arousals, the 17-inch neck. Could you speak to that a little bit more?
Yeah, absolutely. So, what we know about sleep apnea is just the tip of the iceberg, in my opinion. And it's largely focused on symptoms related to men. I find that for women, I will say that that women will probably, we have yet to come to this in the literature. They've got a different phenotype of sleep apnea. That's really what it's all about. So we present differently, and we tend to have more mild to moderate simple obstructive sleep apnea we tend to have clustered events during REM sleep, and that's a different phenotype. And the tools that we use, the diagnostic tools that we use, were not developed with that in mind. So it's more difficult to capture that in a home sleep apnea test. Now, we both know that the gold standard is an in-lab sleep study, but by and large, insurances do not cover that. That's a real problem, because I think that we probably should be using, and I am opening up my private practice, and I'm going to be using a type 2 study, because it does capture more. And then, no shade on the surrogate home sleep apnea testing, but I really think that using peripheral arterial tone for trying to diagnose women is really falling short in helping us determine whether or not women have sleep apnea.
Zooming out again, a lot of women are told, well, this is just part of aging. This is something that happens. There's a lot of myths and misconceptions about sleep in this time of life. What would you want people to know? What do you want to say to clinicians or the women who are struggling?
Not just women, but everybody who's aging says, I'm older now, so I'm not supposed to get good sleep. That is fallacy. We know in order to optimally function, we still need to have enough sleep to get into all of the right sleep stages. And I would say that is a complete misconception and fallacy that is just part of the normal aging process. And that's why I started doing the deep dive into melatonin, because as we age, just generally in the population, and then even more so for women because they are going through menopause, that people have fragmented sleep. They're not getting as much sleep as they were when they love to do the air quotes. When I was young, I slept great, but now that I'm older, I can't. And I really think that there's something there around the loss of melatonin, the fragmentation of sleep, the loss of estrogen, compounding the fragmentation of sleep and causing all of this change in your sleep architecture, and a reduction in your slow wave sleep or N3 sleep, and a reduction in your REM sleep. And those are just the two most important stages of sleep in terms of restorative ability to maintain optimal daytime functioning.
Absolutely. So you have your dream method to help midlife women. Can you tell us about that?
Sure. So my dream method, or dream sleep method, is really a holistic, integrated approach on helping people really figure out what's going on with their sleep. So the D stands for your daily activities. Running around all day, not giving yourself any downtime, certainly will contribute to your inability to actually get to sleep and stay asleep. So that's one component, and that's a high-level summary. The next one is R, or resting environment. You have to have a pretty decent resting environment to allow yourself to sleep. If you're living in a very environment, that is something that we have to then think about. Do you need earplugs? Do you need an eye mask? Do you need blackout shades? What's your mattress like? Is it too hot? Is it too cold? All of these things. So resting environment is really important. And then E is for emotions. We Everyone knows that when you take your worries to bed, that's not going to help you get to sleep. So anxiety, depression, past trauma can all really affect your ability to get to sleep and stay asleep. And then A is archetype, which is really focusing on what your circadian rhythm is. Are you an early bird? Are you a night owl? I call it being an Artemis for early bird, being an Aphrodite if you're a night owl, and being an Athena if you fall into societal norm in the United States. So that to me is your foundation, because once you understand what your circadian rhythm is, then we can work from there. Because if we're fighting against a circadian rhythm, then everything else is not going to fall into place as well either. That's how I start with the A in the dream for most people. And then the last one is medical conditions. And we talked about some of the very common ones like sleep apnea, restless leg syndrome, chronic insomnia. And there's a whole host of parasomnias. There's central disorders of sleep. There's other types of sleep apnea. There's a lot out there.
I really like this dream framework because it captures everything. And Dr. Matsumura has a sleep archetype quiz on her website. So you can go check that out, find out what your archetype is. So how can clinicians integrate this framework into their practice? What's a good place for them to start?
I really think that going back to when I was a primary care doc and just asking how many hours of sleep do you get versus are you getting enough sleep? When people have to think about how many hours of sleep they get, that is the start of the discussion around whether or not somebody might be having trouble sleeping. And so I think that's the first question, and really focusing on if somebody's an early bird or a night owl can really help you help if somebody has delayed circadian rhythm. There's some tools that I have online that help people train other people how to adjust their circadian rhythm. So that's something simple. The other piece is really have a low threshold for sleep apnea. We have such a high prevalence of sleep apnea in our country. And for women, the data is that up to 67% of women may have obstructive sleep apnea. 90% of them don't know that they have it. That's crazy.
That is crazy. Yeah, that is crazy. So in my practice, so I see patients with sleep issues, and I'm a psychiatrist, so I see patients with anxiety and depression. So I see a lot of insomnia. And so I had, I think, 3 or 4 women who were referred to me over the past few months for treatment-resistant insomnia. Like they were referred by their psychiatrists, so their primary care doctors, and they'd cycled through the usual treatment options, trazodone, different sleep aids, maybe a little bit of CBTI, and nothing was really working. And so did the sleep testing. And what did we find out? All of these women had moderate obstructive sleep apnea. So one of them had severe. And it hadn't been thought of, right? That no one had thought to test them because they didn't have that classic presentation. Yes.
I've had so many women cry in my office, so thankful that I believed them that something else was going on. And so I really am glad that we're out there, that there's more female sleep physicians out there who are recognizing this. You brought up cognitive behavioral therapy for insomnia. So I would love to touch on that because I got trained in CBTI during my fellowship. And that is such a cornerstone. And what I tell folks all the time is that you really need to follow it. You can't pick and choose what parts of CBTI. So when people come to me and say, I tried it, it didn't work, I already know that they didn't try all of it.
Exactly. Okay, let's talk about it. This is such a big one, such a big one. So CBTI, cognitive behavioral therapy for insomnia, it is the first line gold standard treatment for insomnia. So one of the misconceptions I'd love you to talk about is that I hear this from other clinicians, but even from patients, there's a misconception that it's the same thing as CBT, as sleep hygiene. So they'll say, oh, wait, no, I have good sleep hygiene. I've done CBTI. It's not the same thing. Could you speak to that and what CBTI is?
Yes. Every sleep doc should be hanging their hat on CBTI.
Yes.
So yes, so it is not just sleep hygiene. So what I tell my patients is that this is not about you getting yourself ready for bed. Most people who have insomnia have an elaborate practice to get themselves to sleep. This is about addressing the learned hypervigilance and hyperarousal in your sleep. That is very different than just having a nice practice to help you get to sleep. And so that's really the cornerstone for, in my opinion, what CBTI is. It's addressing that hypervigilance and providing you with the tools to help train yourself to get back to sleep again. And then addressing the comorbid conditions. So it's not just, oh, you've got chronic insomnia. It's you have chronic insomnia and likely something else causing that chronic insomnia. And they have this interplay, and you need to treat both of them at the same time. And that's so important. And also, that's why there is the specialty sleep medicine, because it takes a specialist to really understand how to treat all of the things that are affecting your sleep.
Yes. Yeah, absolutely. And with CBTI, it's so applicable to lots of different populations, and it's safe because it's a drug-free approach to treating chronic insomnia. And there are benefits for menopause and perimenopause. Could you speak about that?
Yeah, absolutely. A lot of people really poo-poo the fact that CBTI or CBT might help menopause, but I'm a fan of an integrated all hands on deck approach. So I certainly, we know that hormones are life-saving, but a third of my patients who I start on hormone therapy will still have problems sleeping. So then we need to figure out, is it another organic disorder like sleep apnea or restless leg syndrome or a circadian realignment that needs to happen? And then we also talk about cognitive behavioral therapy for insomnia and how that plays a really big role. And a lot of times people will say, but I can't do sleep restriction. There's no way I could do this. And what I tell my patients is that you're here today because what is happening in your life is not working. You feel chronically sleep deprived. 3 to 6 months of some pretty hard work is going to set you up for the next decades of life, for the rest of your life. And you can always come back to these tools to help you improve your sleep. The other piece that I tell folks is that this is not a couch to 5K. This is a couch to marathon, and that this is retraining. It's just like weight. It feels like we can gain weight pretty easily, but when we are in the process of losing weight, it's an entire shift in how you think about food to have sustained weight loss, right? So this is the same with sleep. The last thing that I tell patients is that all the tools are already there. They're already there. We just need to figure out how to use them correctly to build that house, the house of sleep for you.
Excellent. Yeah, that's so good. And that's what I love about CBTI is that it's empowering. All the tools are there, and anything special, you're not relying on a medication or an external sleep aid. It's a skills training program, really,
Right.
and the benefits are not only applicable to sleep. You'll see reductions in vasomotor symptoms like hot flashes in women. I'll see reductions in anxiety and depression during the day
100%.
with people, right? So there's so many far-reaching benefits. You did mention HRT, hormone replacement therapy. So where does that fit into your framework? Like, how do you use that with women who have sleep?
Part of what I do is I use the dream method, but then I also ask women who are in this stage of life, who are in midlife, a whole host of questions around menopausal symptoms. And if they're not on hormone therapy, then we evaluate them to see whether or not they should be on hormone therapy. And virtually every woman can, on some level, be on some sort of hormone therapy. Certainly vaginal estrogen is pretty much available for everyone. But most women, there are a few specific cases. Certainly, if you have had breast cancer in the past or ovarian cancer, there are certain groups who cannot or have to have more finessing around hormone therapy. But I start with that. And then also at the same time, I'm evaluating for sleep apnea. And I have a very low threshold for testing because we just don't have any great screening tools. And a lot of the symptoms that come up for women for sleep apnea, they really get blurred because of this, what I like to say, the biopsychosocial model. Like we have normalized fatigue, disrupted sleep in women. So then it's really hard sometimes to tease out, is that something that you've lived with for decades or is this new? I really, again, have that low threshold for testing women for sleep apnea because we don't want to miss that. And that's a pretty straightforward thing to treat. Now, there's a lot of different options, but we do know that people feel better when they actually get oxygen. So
Imagine that.
yeah, that's how I work in the hormone therapy plus doing a full evaluation for sleep.
And you mentioned that. So were you saying about 2/3 of your patients, midlife women with sleep issues, get better with HRT, or what kind of results do you
Yeah,
see?
generally speaking, yes. Anecdotally, yes. About 2/3 of my patients will get better, will have better sleep. That doesn't mean that they don't have sleep apnea, though, right? So you might have an improvement in sleep, but you still might have disordered breathing and sleep. So we still have to evaluate that. But that 1/3 who is still having problems with their sleep and they are optimized on their hormone therapy, that's when I really start to focus on, could this be cognitive chronic insomnia? Might they benefit from cognitive behavioral therapy for insomnia? And then it will help. It's more of a holistic approach, if you will, when I start to think about all of the reasons why somebody might have trouble sleeping.
Okay, so for the clinician, now they have this midlife woman in their clinic and she's struggling with sleep issues. What's their next step?
I think just by and large, we got to start somewhere. And that first piece is really focusing on whether or not they need hormone therapy. I think that you can capture a lot of people, around 66%, 2/3. That's a lot of people that you can help. And so I would start with that first. And then the other piece, do follow up with them and make sure that you can optimize their hormone therapy. If you can't, then please work in concert with somebody. And then the other piece is just, again, asking how many hours of sleep do you think you're getting? Because that's a real window into somebody's nighttime behavior, whether or not they are getting enough hours of sleep. And if some people might say, oh, I've never gotten good sleep, I always get 5 hours of sleep. That's not normal.
And for the woman who's struggling, what does she do next? Where does she go? Like, how does she find somebody like you who can support her?
I don't have a great answer for that because I really feel like medicine is so broken right now and we don't have the time. When a primary care clinician is seeing patients in 15-minute intervals, this is really difficult. The one thing I would say is go in with only one thing, which is I want to talk to you about my trouble sleep and really just prioritize that and focus on that one single problem for your visit and advocate for yourself. We have to all be our own advocates at this point and the system that we work in. And you can also look on the American Academy of Sleep Medicine, I believe, for sleep medicine physicians in your area. I am trying to put together a list of folks across the country. If I can get one person from every state who might have this interest in focusing on women's sleep in particular, also on midlife stressors and issues around sleep, then I think I will have succeeded in one of my goals around developing my whole sleep medicine practice for women.
Fantastic. That's such a great idea. It's really needed. And then I'm curious, how did you get trained in HRT? Did you do additional coursework, or can you tell us about that?
As a primary care doc, I had to teach myself. That's one of the things that was common for me to actually treat. And so then I took some online courses from some really highly qualified folks like Dr. Rachel Rubin has a course that's out. Dr. Heather Hirsch has a course that's out. I also took or read through the book from the Menopause Society, and then I took their certification exam. So I'm pretty well versed in it at this point.
Okay, so a few rapid fire questions. What's your favorite sleep tool or gadget?
I love a good sleep mask. I love sleep masks because we have too much light in our life. And I really feel that it helps to just reduce that whole sensory input because that tends to be a distractor for many people. And we also know that light is like the strongest cue that we have for wakefulness. So I have, I don't know, like 6 different sleep masks.
Do you have a favorite?
My favorite one is probably the one that I bought in a rush because I forgot mine. I bought it on Amazon. I can't remember the name of it, but I'm actually developing a sleep mask just because I love them and so one of the things I love the silk sleep masks. I don't think that the other masks that are out there breathe as well. So you have to have a silk sleep mask. I think that it's soft, it's breathable, easy to wash. So that's what I would start with.
I can't wait to see the one that you come out with. And what's your favorite sleep indulgence?
Sleep indulgence. I would have to say amazing sheets. You can't go wrong with some really comfortable, soft, cooling sheets. That's my favorite. And they can be pretty pricey, but honest, the Costco sheets are pretty darn for the cost. They work out pretty well. There's some really beautiful sheets out there. And when you get into your bed, just the lap of luxury that I feel that I'm in with amazing sheets and a good mattress, I guess. That's a big indulgence. I don't know. I feel like that's so much of an indulgence as much as it's a necessity. If you do not have a good mattress, then the sheets are just not going to help you. Like you need to have foundation.
Totally agree. Fantastic. Dr. Matsumura, where can people learn more about you? And if they wanted to work with you, how could they do that?
Absolutely. So I do have an Instagram account that I post out daily some sort of sleep tip, and that's Sleep Goddess MD or Dr. Andrea Matsumura. And then my website also is Dr. Andrea Matsumura or Sleep Goddess MD. Either will get you to the website. On my website, I do have blogs. I do have a sleep starter kit. I have the archetype quiz. I try to give people as much information as I can around sleep because it's our CEO. Sleep is the CEO of health.
Totally agree. Wonderful. Thank you so much for joining me today.
Thank you. It was great. It was fun.